Good morning, everyone. I'm going to get started for us. My name is Matilda Bartholomew. I'm one of the medicine chief residents, and I have the pleasure this morning of introducing Dr. Peter Liu. Dr. Liu completed his internal medicine residency and chief residency at the University of Virginia, and then fellowship in infectious diseases at the Hospital of the University of Pennsylvania. After completion of fellowship, he joined the faculty at the University of Pennsylvania, where he served as core faculty member in the ID Fellowship Program, the course director for various UME and GME educational initiatives, and the clinic director for the multidisciplinary non-tuberculous mycobacteria, or NTM clinic. More recently, he joined the infectious disease faculty at the Mount Sinai Hospital. In his current role, he serves as the ID Fellowship Program Director and also spends dedicated clinic time at the Respiratory Institute, where he sees patients with NTM infections in a collaborative program with the Pulmonary Division. Please welcome Dr. Liu.
All right. Well, thank you so much for the very kind introduction. Thank you, of course, for the opportunity to speak here as well. It's really an honor to have the opportunity in this venue. So it's been nearly 80 years since the first case of Mycobacterium avium complex infection was reported in humans. And despite the time that's elapsed since then, there remains a lot of unresolved issues and treatment-related challenges with this old adversary. And today I'm going to really hone in on those that are relevant for pulmonary disease. So I have no relevant financial disclosures, and here are my objectives for today. So I'd first like to start by briefly reviewing the contemporary epidemiology of MAC lung disease. We'll then use a few case-based vignettes to really dive into a brief discussion about guideline-based recommendations for the diagnosis and treatment of MAC, before dovetailing into a little bit more of a discussion related to ongoing clinical conundrums and unsettled questions. Finally, I'll conclude by briefly highlighting emerging and in many instances really repurposed therapeutics for MAC. So to lay the groundwork for this talk, Mycobacterium avium complex, or MAC, really encompasses 12 distinct subspecies of non-tuberculous mycobacteria, or NTMs, which are really ubiquitous in environmental reservoirs all around us, including the soil and water. And why should we care? Well, amongst all NTMs, members of MAC, in particular M. avium and M. intracellulare, are really the principal causes of NTM lung disease, which accounts for a considerable amount of cost, morbidity, and mortality in our aging population. In fact, in some data that came out of Germany in 2017, there was a reported nearly four-fold increase in the mean direct medical expenditure for patients with NTM lung disease compared to matched controls. Additionally, some separate observational data suggests that the 10-year mortality from MAC lung disease may in fact approximate 15%. Now, the epidemiology of MAC lung disease is difficult to precisely define. MAC is actually not a reportable condition, and most of the estimates out there have really been predicated on large claims databases as well as isolation rates within specific geographic catchments. What does seem to be clear, however, is that there's been an overall acceleration in the incidence and prevalence of NTM disease over time. And so here you can see on the left-hand side the reported annual isolation and disease prevalence of MAC lung disease in Ontario, Canada between 1998 and 2010. Actually, some follow-up observational data from this same geographic region also found that the prevalence of MAC lung disease has increased over 2.5-fold in 2020 compared to 2010. And really, there were similar trends observed in Hawaii. This is on the right-hand side, some data from the Kaiser Permanente system there, which depicts trends between 2005 and 2013. In a separate analysis of a large managed care claims database, it's also been observed that the annual incidence and prevalence of NTM lung disease has really increased across much of the country, as you can see, between 2008, which is shown on the left-hand side here, and 2015, which is shown on the right-hand side. Specifically, the annual average increase in the incidence and prevalence of NTM lung disease was 5.2 and 7.5% respectively over this time period. Now, the exact reasons for these observed trends are not entirely defined, but it does appear that there is a true uptick in the incidence as well as perhaps an improvement in clinical microbiology or diagnostic microbiology, clinical recognition, as well as just an increase in the overall background rate of chronic lung diseases. So as I mentioned, NTMs, including MAC, are really ubiquitous in the world around us, but only a minority of individuals seem to develop clinically apparent disease. And this is likely due to the complex interplay of a variety of factors that can really be thought of within the framework of something called the MAC exposome. So there are some well-described environmental reservoirs of MAC. These again include the soil and water. MAC also has the propensity to form biofilms, which actually have innate resistance to relative heat, as well as disinfectants such as chlorine, which likely underscores why we can so readily culture MAC from different foci, such as the municipal water supply, drinking water, and showerhead aerosols. There are also certain activities that might expose an individual to a higher than usual inoculum of MAC, and so this might include folks who are participating in regular gardening or using hot tubs, saunas, or indoor swimming pools. And finally, there are a myriad of host factors that are at least associated with the development of NTM lung disease. So this includes structural lung disease that can be seen in conditions like cystic fibrosis, COPD, or other non-CF associated bronchiectatic conditions. There are also some immunodeficiencies worth mentioning, in particular defects along the interleukin-12 and interferon gamma pathway that are relevant. And patients who have GERD with microaspiration, who have very low BMIs, or certain thoracic skeletal abnormalities such as pectus excavatum, have also been seen to have higher rates of NTM lung disease compared to the general population. I'll also just mention that there's also a reasonably large population of patients in whom no clear predisposition is found. But with all that in mind, in general, it is thought that when a host with one or more of these susceptibility factors encounters a cumulative threshold of exposures, it's really the kind of complicated relationship between all of these factors that ultimately underscores their longer-term risk of developing MAC lung disease. So with that backdrop in mind, I wanted to segue into a clinical case that I think really highlights some of the foundational concepts related to the diagnosis and management of MAC. So this was a patient I met a few years ago. So she was a 68-year-old female who initially actually presented to her primary care physician with a complaint of chronic cough. After an unsuccessful trial with a PPI, she was sent for a CT of the chest that remarked on scattered pulmonary nodules, tree and bud opacities, and bronchiectasis. She subsequently had multiple expectorated sputum cultures sent, most of which had high semi-quantitative growth of macrolide susceptible MAC. She denied a history of tobacco use disorder and had a negative workup for aspiration, hypogam, and HIV. When I met her, she specifically denied dyspnea on exertion or B symptoms, though did report that her cough was very bothersome to the point that it was really disrupting her motivation to participate in social activities as well as her sleep. And here are some representative images from her CT of the chest. And as you can see here, there are various foci of these tree and bud opacities. And as you move more inferiorly, you'll also appreciate that there's some more emerging bronchiectasis and perhaps in this cross-sectional slice, more evidence of these pulmonary nodules. Now, again, as I mentioned, NTMs, including MAC, are so ubiquitous, right? And so therefore, they can be very easily recovered as colonizing microbes. And really, as a function of this, there are very intentional diagnostic criteria that have been put in place from the American Thoracic Society and the ID Society of America. So as you'll see here, in order to establish a diagnosis of NTM lung disease, patients need to have respiratory symptoms. They also have to have compatible radiography, which is really typified by the presence of nodules, bronchiectasis, cavities, or a combination thereof. In addition to that, there are specific microbiologic criteria that need to be met as well. So in general, this requires at least 2 or more expectorated sputum cultures that have concordant growth of the same NTM. Or alternatively, a single specimen can suffice if it's taken by way of bronchoscopy or bronchial biopsy, specifically if it's accompanied by compatible histopathology. So the patient in our vignette met diagnostic criteria by way of having respiratory symptoms, compatible chest radiography, and as you'll recall, 3 out of 4 specimens with high semi-quantitative growth of MAC. So now that we've made a diagnosis in this case, where do we go from here? Well, importantly, just because a patient meets diagnostic criteria does not immediately oblige them to antimicrobial therapy. In fact, there's several studies that showcase that a proportion of patients with MAC lung disease will actually not have progression of infection despite an absence of antimicrobials for a period of time. Therefore, the decision to start combination therapy should really be made on an individualized basis. So in one observational study from a large academic center in South Korea, 420 patients with a new diagnosis of MAC lung disease were followed for at least 3 years with a median follow-up duration of 5.6 years. And as you can see in this study, 115 of the 420 patients, representing 27% of the total study population, remained without clinical, radiologic, or microbiologic evidence of disease progression after at least 3 years of follow-up. Now, importantly, this study did include patients with both non-cavitary and cavitary lung disease, which likely selected for a pretty sick study population at baseline. So in a follow-up study, Kwan and colleagues actually included only those who had non-cavitary MAC lung disease. And as you can see from this graphic, of 551 patients who were included, 228 of them, representing 41% of the study population, again, remained stable off of antimicrobials for at least 3 years of follow-up. This group then went on to have additional longer-term follow-up with a median duration of 5.8 years. And actually, over this extended follow-up duration, 25 patients did have evidence of disease progression and were therefore started on antimicrobials. But the remaining 203, which represented, again, 37% of the original study population, did not have evidence of disease progression after this extended follow-up period. Interestingly, this group ultimately, when investigators kind of looked back, they realized that over half of these patients actually achieved spontaneous sputum culture conversion, meaning that they had 3 consecutive negative sputum cultures over this extended follow-up duration in the absence of antibiotics. So clearly, not every patient who meets diagnostic criteria will have progressive MAC lung disease, but what factors are associated with progression? Well, acknowledging the limitations to observational data from which most of this is derived, the literature does report on a fair number of clinical properties or clinical factors rather that do seem to be associated with disease progression. So I've included many of them here. So this includes folks who have a lower BMI at the time of diagnosis, who are of male sex. Perhaps unsurprisingly, patients who have more lobes involved, who have cavitary disease or smear positivity are also likely more likely to progress over time. There's also some non-specific lab abnormalities that I think really just point to a chronically inflamed state. So folks who have anemia, hypoalbuminemia, or an elevated SED rate have also been seen to exhibit a higher likelihood of disease progression over time. And I think as a function of this, instead of a one-size-fits-all approach to each patient, I think really a comprehensive evaluation of the individual needs to happen in each circumstance where we really weigh the risks and benefits of antimicrobial therapy. What I do with my patients, I pretty much take a shared decision-making approach where I really think through the presence or conspicuous absence of some of these factors. And I've actually included asterisks next to those that I put a little bit more weight on. So the folks who have low BMIs, cavitary disease, or smear positivity. Some additional considerations that come to mind for me, which actually typically lower my threshold to start antimicrobials, are the presence of cystic fibrosis as a comorbidity, systemic symptoms on presentation, or having an immunosuppressed status. So in this particular case, I favored starting antimicrobials in this patient owing to the large semi-quantitative burden of organism on her cultures, as well as the very disruptive respiratory symptoms that she had exhibited on her initial clinic visit. So how do we go about constructing treatment regimens? Well, the existing literature would suggest that we should be discerning between those who have nodular bronchiectasis and those who have cavitary disease. So in the setting of nodular bronchiectasis, the backbone regimen should consist of a macrolide, rifamycin, and ethambutol. Now you'll see here that as far as the macrolide piece goes, either azithromycin or clarithromycin can be used, but in general, we typically favor azithromycin because it can be dosed once daily, and compared to clarithromycin, tends to be a little bit better tolerated. Similarly, as far as the rifamycin goes, you can use either rifampin or rifabutin, although I'll mention that if you are going to use rifabutin in this context, it should not be co-administered with clarithromycin, as there is a drug-drug interaction there that increases the risk of drug-induced uveitis. Now you'll note for patients with nodular bronchiectasis, we can treat patients with 3 times weekly antimicrobials, and that's owing to some comparative data showing similar clinical outcomes in those who are treated with daily or 3 times weekly regimens, but the 3 times weekly regimens tend to be much better tolerated. Now contrast that to those who have cavitary disease. Clinical outcomes in this setting are actually much more poor, and so you'll see that there are some differences in suggested treatment paradigms here. So although the oral backbone remains the same, so a macrolide, rifamycin, and ethambutol, it's recommended that these medications be administered daily. And in addition to this oral backbone, a fixed duration of a parenteral aminoglycoside, specifically IV amikation, should also be considered. Now, there's no standardized guidance as far as how long to use IV amikacin for, but I'll mention in my clinical experience, this typically falls somewhere in the realm of 4 to 15 weeks, really just kind of owing to individual patient tolerability. So here is a little bit of a framework for how I structure follow-up and safety monitoring for patients who are being actively treated for MAC lung disease. So I typically see patients in clinic about every 2 to 3 months, and I get sputum cultures with at least that frequency, if not more often. Patients will also get safety monitoring blood work done at each visit. And you'll note here that it's important to also be mindful of relevant referrals that need to be placed based on long-term potential medication toxicities. So specifically referrals to audiometry and ophthalmology for patients who are on amikacin and ethambutol respectively. Now there's no specific guidance as far as how often to get radiographic follow-up in these patients. I tend to be a little bit more of a less is more type of guy in this space. The times where I often will repeat chest CTs are in folks who are having a clear deterioration in their clinical symptoms, or sometimes just before the end of proposed treatment to sort of establish a new radiographic baseline. Concordant with guideline recommendations, the treatment duration really should mirror that of 12 months following culture conversion, which has been historically defined as having 3 consecutive negative sputum cultures. So what did I do with this first patient presented? So I initiated her on 3 times weekly azithromycin, rifampin, and ethambutol. And unfortunately, she developed what appeared to be drug-induced liver injury due to rifampin. We ended up having to interrupt all of her medications and start them back one by one with basically close laboratory monitoring in between. And really in this setting, we were essentially forced to continue with azithromycin and ethambutol with an indefinite pause on rifampin. And so really the question at this point that arose is, where do we go from here? So as far as we've been through this case so far, I think we've talked about how to establish the diagnosis of MAC lung disease. We went through some of the factors that I think go into making that decision regarding initiation of antimicrobials versus taking a little bit more of a watchful waiting approach. Also introduced a little bit of a framework for constructing an initial regimen and how to do safety monitoring. But I think 2 outstanding questions that this case now raises is, first being, do we really need all these drugs? And secondly, could we actually predict who may turn out to be treatment refractory? So the current US guidelines recommend a 3-drug regimen over a 2-drug regimen for macrolide susceptible MAC lung disease. And you'll note that this is a conditional recommendation made with a low level of certainty. Now I need to emphasize that for susceptible isolates, the macrolide, or typically azithromycin, really should be a critical component of the regimen, which should be considered really the cornerstone of therapy for all susceptible isolates. There is actually a little bit of precedent for using two-drug regimens, and actually when this has been done, this is typically done by combining azithromycin with ethambutol, because there's actually very good in vitro and to some extent clinical data that supports this notion of ethambutol being a great companion drug to actually protect against treatment-emergent macrolide resistance. Now, unfortunately, there's actually no data as to whether 3 versus 2 drug therapy is actually more protective against macrolide resistance emerging. And it's really for this reason that the guideline panel was swayed to recommend a 3-drug treatment regimen in this setting. Now, the only published study to my knowledge that actually looked to better define this actually came out of Japan in 2013. So this was actually a study by Miwa and colleagues that included 119 patients in a single center non-inferiority randomized trial. And as you can see here, they compared 3 oral drugs to 2 oral drugs, with the 2-drug group omitting the rifamycin. Now, both groups in the study were actually well balanced in terms of baseline characteristics, so age, BMI, smoking status, and rate of cavitary disease. And the primary endpoint of interest for investigators here was really the proportion of patients that achieved sputum culture conversion, which they defined as having 3 consecutive negative sputum cultures by a fixed duration of 12 months of therapy. So in this study, in the intention to treat analysis, 40% of patients met the primary outcome measure in the 3-drug group rather, and 55% in the 2-drug group. This actually met the pre-specified non-inferiority margin in the intention to treat analysis, but not the per protocol analysis, as you can see. And the question is, why was this the case, and why did this study perhaps not garner a little bit more attention? Well, there were some notable limitations, several of which I've highlighted here. So the drug doses used in this study were actually much lower than are typically recommended. For example, clarithromycin was dosed as 200 milligrams BID or TID. This was an unblinded study, and patients were actually treated for fixed 12-month durations instead of durations recommended by guidelines, which are typically 12 months following culture conversion. I think you can also appreciate that there was an enormously high dropout rate in this study, nearly 50% in the 3-drug group and a third in the 2-drug group. And unfortunately, this study itself was underpowered to actually detect a difference in the rate of macrolide resistance between the 2 groups. So clearly, I think the debate of 3 versus 2 drugs remains a bit unsettled. And again, when 2-drug therapy is attempted, it's typically done with the combination of a macrolide and ethambutol. But it's really the role of the 3rd agent, specifically the rifamycin, which remains somewhat undefined. So I think this audience is very familiar with the notion of rifampin being a very potent inducer of cytochrome P450. And as a result of this, when co-administered with azithromycin, it will reduce peak plasma concentrations known as Cmax of macrolides, which again are the cornerstone of therapy for susceptible isolates. Now, perhaps unsurprisingly, the quantitative Cmax will actually differ depending on whether you're dosing it at 250 or 500 milligrams, which are the doses recommended for daily and intermittent therapy, respectively. So in a study that came out from South Korea in 2016, investigators looked to describe the drug-drug interactions between rifampin and azithromycin, and to also describe the association between the Cmax of azithro and treatment outcomes. So in this study, this was a single-center observational study that included patients with MAC or Mycobacterium abscessus lung disease who were treated and had therapeutic drug monitoring done between 2012 and 2013. And as you can see here on the right-hand side of this flowchart, patients with abscessus lung disease were really included almost as a control group, because by way of guideline recommendations at that time, these patients would have received a macrolide in the absence of a rifamycin, so it wouldn't have had that influence on therapeutic drug monitoring with co-administration of those drugs. On the left-hand side here, you'll see that 166 patients with MAC lung disease were included. 77 of them received daily treatment regimens, 89 received intermittent therapy. Throughout this study, all of the constructed regimens were concordant with guideline-based recommendations. And the investigators here were really interested in the proportion of patients who had a favorable microbiologic response, which they defined as having 3 consecutive negative sputum cultures and maintenance of negative sputum cultures for 12 months thereafter. So here's the box and whisker plot for the peak plasma concentrations, or Cmax, of azithro in this study. So I know this shows up fairly small, but as you may be able to see, the median Cmax was 0.22 in those who received daily therapy, and that compared to 0.66 and 0.53 for those who received intermittent therapy or a macrolide in the absence of erythromycin. Now, previous data suggested that a target Cmax for pulmonary MAC and azithromycin might be approximately 0.2. And you can appreciate here that a greater proportion of patients who received daily therapy had a Cmax less than 0.2 when compared to the other two groups. Now, additional analysis revealed that within the daily group, a higher peak plasma concentration of azithromycin was actually associated with a favorable microbiologic response. And in particular, when Cmax was greater than or equal to 0.4, there was an even stronger association with an adjusted odds ratio of almost 4. Now, there were some notable limitations in this study. I think perhaps most conspicuously was some differences between the different groups in terms of the study population. So perhaps unsurprisingly, there was actually more patients in the daily treatment group who had cavitary disease compared to the other two arms. So what did we actually learn from this study? Well, I think that this study showed that on average, patients who are treated with daily regimens have lower peak plasma concentrations of macrolides. Now, what the specific in vivo kind of impact of that is, that remains somewhat undefined in this study. But I think this data is interesting, and even acknowledging its limitations, I think it does call into question really what the role of the erythromycin is in a biologically plausible way. So what other work has been done in this space since that publication? Well, some preliminary data from something called the ARISE study was presented at the CHEST meeting last year. So this was a randomized trial that looked at 3 versus 2 drugs in patients with non-cavitary MAC. But you'll note that the third drug here is something called ALIS, which stands for amikacin liposomal inhalation suspension. We'll talk about that here a little bit. The investigators here were really interested in the proportion of patients who achieved culture conversion, which was defined as having 2 consecutive negatives. And as you can see here in the preliminary data, a higher proportion of patients had culture conversion who received 3 drugs instead of 2. There is also a more of a continuation study called the ENCORE trial, which is currently ongoing. Similar setup to the ARISE study, 3 versus 2 drugs, with that third drug being ALIS. However, there are more centers involved, a higher N, a longer duration of follow-up. This is still very much a work in progress, and so we don't actually have any preliminary data from this, but some is expected perhaps later this year. I also mentioned that there is a clinical trial going on, which is of tremendous interest to me. This is something called the MAC 2v3 trial. So this is a multi-center RCT that's looking at 3 oral drugs compared to 2 oral drugs for MAC lung disease. The 2-drug group includes has the omission rather of the erythromycin. So this trial actually completed target enrollment towards the end of the last calendar year. And so there's some optimism that we'll see some preliminary data from this probably in the next couple of months. So the other question I think that was important to think through in this particular case was, can we predict who might become treatment refractory? So you'll remember that guideline recommendations, again, are to treat patients for 12 months following culture conversion. And that's really an awfully long time, especially when we think about patients who might be labeled as being treatment refractory, which has been historically defined as people who have persistently positive cultures despite 12 months of therapy. I think many would argue that really waiting a year to label somebody as having failed treatment is an awfully long time. And so there fortunately is now some evidence to suggest that we might actually be able to determine patients who are likely to fail treatment a little bit earlier into their treatment course so that we might be able to catalyze an appropriate adjustment to their antimicrobial regimen. So this was a study by Moon and colleagues, which included 470 patients with MAC lung disease. And of those 470, 357, representing 76% of the study population, achieved culture conversion by 12 months of treatment. Now, as you can see here on the left-hand side, the majority of patients who converted their sputum, 94% of them, had this evident by 6 months of treatment. And similarly, if you go to the other side of this figure, the remaining 113 patients, so 24% of the study population, unfortunately did not convert their sputum cultures after a year. But again, the majority of these individuals could have been identified by month 6, as they essentially had evidence of persistent culture positivity at that particular point in time. Now, there was a separate study also done by Griffith and colleagues that included 180 patients who had MAC lung disease, who were treated with antimicrobials, and who had at least 12 months of follow-up data. And investigators in this study were really interested in trying to understand whether semi-quantitative culture scores could really predict the longer-term likelihood of sputum culture conversion. So in this study, sputum specimens were collected every 1 to 2 months, and semi-quantitative scores were assigned as negative or 1 to 4 plus based on colony count. Now, as you can see from this bar graph, at baseline, there was not a huge difference between baseline semi-quantitative culture scores between converters in blue and non-converters in red. But by month 1, converters were already performing much better than non-converters. And if you turn your attention to this table, you'll see that incremental improvements in semi-quantitative culture scores between baseline and month 2 and baseline and month 3 were actually strongly correlated with the longer-term likelihood of achieving sputum culture conversion, with odds ratios of 6.9 and 3.9 respectively. So there was similar data shown in other studies, and I think taken together, really what this tells me is that culture status or improvements or a decrease in semi-quantitative organism burden by month 6 likely predicts subsequent response to therapy. So to wrap up this first case, understandably, this patient had quite a bit of apprehension to remain on antimicrobials after the incident, drug-induced liver injury. But we talked through quite a bit of these different variables and clinical factors in her particular case, and we made the shared decision to continue on 2-drug therapy with azithromycin and ethambutol dosed 3 times weekly. Fortunately, she ended up tolerating this particular regimen without any additional adverse drug events. She converted her sputum cultures by month 4. Her cough improved, although it did not entirely resolve, and she did complete her planned duration of therapy about a year ago at this point. And as of the last update that I got from the fall of last year, she was doing quite well without any evidence of microbiologic relapse. So I'm now going to segue into the second case, which I'll highlight today. So this was a different patient who I also met a few years back. So this was a 23-year-old female who had a history of cystic fibrosis. You can see that she was on CFTR modulator therapy, and she was referred to me for additional considerations for MAC lung disease. So she actually had all of her care at another institution before her referral. But in that setting, she had repeated hospitalizations for CF exacerbations in the preceding months. And over that time period, she really had serial respiratory cultures that demonstrated an increasing semi-quantitative burden of MAC. So when I met her, she denied any changes in her baseline chronic cough, but did report an increase in dyspnea and exertion, as well as some new periodic night sweats. And I've included some images from her initial CT scan, which really highlight here that she's got a focus of infiltrate with bronchiectasis, a component of cavitation that's really centered in the right upper lobe. But as you move more inferiorly, other than some focal bronchiectasis, the remainder of her airways and a parenchyma appear largely spared of this process. So here was her pertinent microbiology, and unfortunately, as you can see, she had an enormous organism burden on her sputum cultures, and unfortunately, although she had a low MIC to amikacin, this isolate was macrolide resistant. So when we can't turn to the usual guideline-based approach to treat MAC lung disease, what other options are in the armamentarium? So I'm going to take you through a quick whirlwind tour of some of the other options that we have. And I'm going to first start by mentioning clofazimine. So clofazimine is actually a drug that was originally studied for the treatment of leprosy, which is caused by a different non-tuberculous mycobacteria called M. leprae. Over the years, though, there's been fairly encouraging both in vitro and to some extent clinical data suggesting that clofazimine also has a role in the treatment of other NTM infections. So some of the things we like about clofazimine is that it's available free of charge through an expanded access program from the manufacturer. There are a couple of just practical notes to be aware of for clofazimine. So it has an enormously long half-life, as you can see. And in order to successfully take clofazimine, patients need to be able to take PO on their own. And the reason for this is really, I think, exemplified in this photo in the bottom right-hand side here, which shows the internal contents of a clofazimine capsule. So if you're ever to open one of these up, the internal contents is this really thick, viscous, almost mud-like compound. And so if you were ever to try to open this and administer this through enteral access, for example, the contents would merely adhere to the side of the tubing. So clofazimine tends to be reasonably well tolerated. You'll see here that there is an association with QTc prolongation and to some extent some GI distress. The thing worth mentioning is that actually most patients who take clofazimine for an extended duration will have some degree of hyperpigmentation. So for most individuals, this actually looks like they have a summer tan, even if it's in the middle of winter in New York City. But for a minority of individuals, this actually will be a little bit more prominent, asymmetric, and sometimes cosmetically bothersome. So what I tell all patients is, if this happens to you, let me know right away. If you stop drug promptly, things tend to revert back to the pre-existing baseline, although it can take a very long period of time just owing to the very long half-life of the drug, as you can see here. I'm also going to mention ALIS, which was briefly highlighted in a prior slide. So again, this stands for amikacin liposomal inhalation suspension. And this is an inhaled antibiotic that's approved for the treatment of treatment refractory MAC lung infection, which has been defined as folks who have persistently positive cultures despite 6 months of oral therapy. Some of the interesting preclinical data on ALIS suggested that compared to the compounded parenteral version, ALIS actually has a greater ability to penetrate biofilms and achieve higher concentrations in distal lung tissue. Now, the efficacy of ALIS looks pretty good, and I'll highlight such from a clinical trial on the next slide. But in my clinical experience, some of the challenges with ALIS are really related to tolerability. About half of patients will have some component of dysphonia present while taking this drug, and to a lesser extent, temporally associated bronchospasm that can be at least partially mitigated by pretreatment with albuterol. Now, the FDA approval for ALIS actually came after the publication of something known as the CONVERT trial. So this was a randomized controlled trial that included 336 patients who had treatment refractory MAC lung disease, so people who had persistently positive sputum cultures despite 6 or more months of oral therapy. And they were basically randomized 2-to-1 to receive ALIS plus guideline-based therapy or guideline-based therapy alone. And investigators were interested in the proportion of patients who achieved culture conversion by 6 months. And as you can see here, the rates of culture conversion between the two groups in a very kind of treatment refractory population were relatively low, but it was significantly higher in those who received ALIS. I will also mention bedaquiline. So bedaquiline is an oral medicine that is FDA approved for the treatment of multi-drug resistant TB. Unfortunately, in the space of NTMs and specifically MAC, there's actually very little data on the use of bedaquiline. There's actually a lot of encouraging in vitro data, but the clinical data is really relegated to case reports and a very small case series that has an N of 10. Just a few practical pointers about bedaquiline. You'll note that there's a loading dose dosing scheme before transition to a 3 times weekly steady state dosing. It should not be co-administered with rifampin, because rifampin actually leads to very rapid metabolism of drug. Like clofazimine, bedaquiline does have the propensity to be associated with QTc prolongation, and I find some of the manufacturer labeling to be a little bit tricky here. So there was a randomized trial that was published in the New England Journal a little over a decade ago, in which there was a increased risk of death in the group that received bedaquiline. And the reason for this was never entirely defined, including in a post hoc analysis. So there's now a black box warning on bedaquiline that basically says there was this unexplained increased risk of death in one clinical trial, just sort of FYI. I think from maybe a little bit more of a reassuring standpoint, There have been several clinical trials that have been done since then, and this signal has not been redemonstrated, but it does continue to persist on the label for this drug. I think many of us in the audience are probably a little bit more familiar with linezolid, which is an oxazolidinone, but I wanted to highlight tidozolid today, which is also within the oxazolidinone class, but I think carries some distinct advantages compared to linezolid. So there's actually quite a bit of experience with using linezolid as a salvage option for the treatment of MAC, and there's now really more and more in vitro data to support the use of tidozolid in this space as well. In fact, some of the in vitro evidence suggests that tidozolid on average probably has 2 to 4-fold lower MICs compared to linezolid. So why do we prefer tidozolid? Well, tolerability is sort of the main thing. So this, as you can see, is an agent that can be dosed once daily. And compared to linezolid, it seems to have a lower incidence in bone marrow suppression and cytopenias. We don't know exactly what the relative incidence is. The literature suggests this is probably somewhere in the 40% range, although the caveat being most of this data comes from post-marketing studies related to shorter durations of treatment, such as that for soft tissue infections and bone and joint infections. The other thing that I'll mention that I think is actually a huge advantage of tidozolid is that it is a weak and reversible inhibitor of monoamine oxidase A and B. So as a result, you can actually co-administer tidozolid with medications that are very commonly prescribed, like SSRIs, SNRIs, without having to worry about serotonergic toxicity. I also wanted to briefly mention dual beta-lactams. So a lot of the original data for dual beta-lactams was actually derived in the space of Mycobacterium abscessus infections. And the reason why it was thought to be effective in that setting is M. abscessus actually has something called LD transpeptidases, which are basically used to catalyze peptidoglycan synthesis and cell wall synthesis as a result. In the more recent years, it's been demonstrated that MAC, perhaps unsurprisingly, actually has a very similar cell wall to abscessus and also, in fact, uses LD transpeptidases. And so it's been hypothesized that perhaps there's a role for this in the treatment of MAC as well. And there's been a couple of published in vitro studies on this. I'm just going to highlight one, which actually came from some colleagues at Case Western last year. But in this study, they basically performed in vitro susceptibility testing for different MAC isolates with meropenem, ceftaroline, cefdinir, and cefuroxime, all in individual tests and then later in combination. And essentially what was shown was that combinations seem to be associated with much lower MICs. You can see here in this graphic that this appeared to be most pronounced with the combination of meropenem and ceftaroline. And this has raised, I think, a lot of intrigue with using dual beta-lactams in more salvage situations, but the clinical anecdotes to this point are still relegated to case reports and small case series. So in addition to antimicrobial therapy, certain patients can actually be considered for surgical resection of their infection. I've often prioritized this for patients who have focally advanced, cavitary disease, really with an intent to debulk the primary focus of infection. I've also considered this to be, a valuable option in folks who are treatment refractory, specifically when they have some of the more challenging causative pathogens, such as macrolide-resistant MAC or abscessus. And really over the years, there's been an increasing focus on less invasive techniques, which is really highlighted in that cartoon graphic here. Now, the data to really inform outcomes in patients who are treated with medical and surgical therapy are really constrained by a lot of selection bias. There's been a lot of differences in patient age, general comorbidities, causative pathogen, and frankly, how post-surgical outcomes were measured. What does seem to be clear from the literature, however, is that the rate of postoperative sputum culture conversion seems to be quite high. And I've compiled just 6 of the reasonably well-cited publications here just to highlight that in these 6 publications, the rates of postoperative sputum culture conversion ranged from 84 to 100%. In general, surgery in this space appears to be well tolerated, at least in the literature. There are certainly complications that are reported in some patients, but it seems to be relatively low in the maybe 7 to 9% range most of this is surrounding the presence of a prolonged air leak or spillage of infection into adjacent parenchyma, and to a much lesser extent, the development of the dreaded bronchopulmonary fistula. So I also wanted to mention airway clearance. So we talked a lot about antimicrobials today, but airway clearance is a very important component of the treatment paradigm for patients with MAC lung disease. And with very few exceptions, I basically do this as companion therapy for pretty much all patients, including for those who actually aren't actively prescribed antimicrobials. So what does this look like? Well, this typically involves the combination of hypertonic saline nebulization in addition to use of a positive expiratory pressure device, either in acapella or in aerobica, both of which are pictured here. And I'll mention that most of this, the data for airway clearance actually comes from the cystic fibrosis literature. But I find this to be very helpful in certain patients, particularly those who are either unable or unwilling to exercise, but still have some degree of daily mucus production. I feel like these supportive treatments really kind of help get them over the hump at clearing reasonable amounts of sputum on a daily basis. I also wanted to point out that there are some great patient-facing resources that are actually electronically available from the National Jewish Health System, as well as the Cystic Fibrosis Foundation. And there's actually some great kind of picture-based, step-by-step diagrams for how to appropriately use airway clearance devices. Here at the Respiratory Institute, where I have my clinic, we're also very fortunate to have some resources in place so that patients can actually come for one-on-one visits when we're newly starting them on airway clearance to really have a step-by-step in-person instructional tour through using these devices. So the last thing I'm going to mention today is phage therapy. So there's actually been increasing enthusiasm in exploring the application of bacteriophage therapy for very recalcitrant infections, and that includes those due to NTMs. So this is actually an interesting publication in Clinical Infectious Diseases from a few years ago, which really kind of more described the experience with a compassionate use phage protocol at the University of Pittsburgh. So in this descriptive analysis, there were 20 patients included. As you can see, unfortunately, only one had MAC. But some of the interesting things that came out of this study were that, for those who received phage therapy, a little over half appeared to have a favorable clinical response. And phage therapy appeared to be relatively well tolerated. There were actually no major adverse events. And interestingly, 8 of these 20 patients actually developed neutralizing antibody titers to at least one or more of the phages in their cocktail, but that didn't entirely seem to predict the likelihood of favorable clinical outcomes, as half of these patients went on to have what was later determined by investigators to be a favorable response. So I think, an interesting space for which we certainly need a lot more data, but it will be interesting to see in the coming years whether this might be something that we can more reliably consider in our more advanced recalcitrant infections. So to just close the loop on the second and final case here, so you'll recall that this was a patient with cystic fibrosis who had cavitary right upper lobe MAC lung disease with a macrolide-resistant isolate. So she was started on clofazimine, tedizolid, ethambutol, and IV amikacin. We deferred the use of erythromycin here due to a significant drug-drug interaction with her CFTR modulator therapy. And unfortunately, she, although her semi-quantitative burden of MAC appeared to get a little bit better, she did have persistent culture positivity for the ensuing 4 to 5 months and described really worsening dyspnea on exertion as well as B symptoms that were that correlated with a decrement in her PFTs. So after an extensive multidisciplinary discussion, she was ultimately sent for a right upper lobe lobectomy. We continued her on antimicrobials for 4 months postoperatively. I'm happy to say that she did achieve culture conversion basically in the immediate post-op setting, and to this point has actually remained without evidence of relapse for over 2 years of follow-up. And I've included some images from her more recent CT scan here, which of course highlight the receipt of the right upper lobe lobectomy, but demonstrate that as we move more inferiorly, her airways appear to continue to be free of this process. So for my conclusion slide, I was just going to introduce my kind of framework for how I treat and approach MAC lung disease. So the first question I ask is the isolate macrolide susceptible? And fortunately, in the majority of instances, that answer remains yes. The next question to ask is really, does this patient have cavitary disease or not? If the answer is yes, they should be treated with a daily backbone oral regimen that includes azithromycin, rifampin, and ethambutol. And you'll recall that a fixed duration of a parenteral aminoglycoside should also be considered in this setting as well. If they don't have cavitary disease, if they have nodular bronchiectasis, you'll recall that the treatment regimens can be administered 3 times weekly. And the oral backbone remains the same, and I've put an asterisk next to rifampin just because I think we still don't entirely understand the role of that agent as the third drug. For the unfortunate instances like the second case highlighted today where the organism is actually macrolide resistant, I tend to approach this sort of like I do cavitary disease. So of course you can't count azithromycin as an active agent, but I generally include the same kind of backbone of the regimen. And in addition to that, I try to add 1 or 2 other agents, and you'll remember that the list is not terribly long, and these were the ones that we discussed today. And I try to draw from these largely based on patient tolerability and accessibility to off-label use. A couple of other things that we talked about include this notion of monitoring, sputum cultures and strongly considering intensification of therapy by month 6 if they're not clearing their cultures by then. We talked about the importance of using airway clearance as an adjunctive treatment in addition to antimicrobials. There are selective patients, in particular those who have focal cavitary disease who would otherwise be reasonable surgical candidates who can be considered for lobectomies. And then I think in the background of all of this, things that are, again, important to remember about are to address any underlying risk factors if somebody has ongoing uncontrolled GERD with aspiration, trying to mitigate some of those things. And then, of course, for selective patients who have very low BMIs, connecting them with nutrition support to really optimize things in that space is also important. So with that, that was the end of my talk, and thank you so much for your attention today, and I'm certainly happy to take any questions if anyone has any.
Thanks, Dr. Liu, for a terrific overview of a very important clinical challenge. Yeah.
Yes, thanks, Peter. That was great. I like the framework, but I wonder if we can dive into the majority of patients who have NTM and positive cultures who don't require treatment. And so then, what are your thoughts about best approach to monitor objective criterion for those patients, whether it be lung function, whether it be cough frequency, whether it be imaging abnormalities? And in your view, does that always correlate with sputum clearance if they are treated or not? Because I'm not sure it does.
Yep. Cap, I appreciate that question. And so for those online, the question was really about kind of diving a little bit into how to keep close surveillance on patients who aren't initially started on antimicrobial therapy, but who have a diagnosis of NTM or MAC lung disease. So, the way that I approach these patients is usually, when I go through the clinical factors that are associated with progression or not, we sort of make the decision then about starting antibiotics or not. And for the folks who don't end up on antibiotics, I typically like to get sputum cultures on them about quarterly. And I check in with them usually for the first year on a quarterly basis to really make sure we have close eyes on symptom evolution or lack thereof. I don't often include imaging as part of that mix unless there is a deterioration in clinical symptoms. And sometimes I'll use that as a little bit more of a platform to further discuss antibiotics with them. But I would say, quarterly sputum for the first year. I usually space that out to about twice annually after that if the patient's doing well. And then, airway clearance, which, I very briefly talked about today, usually is a, cornerstone of what we're doing for patients at that point in time. So if they have bronchiectasis, just really focusing on using positive expiratory pressure devices, in some cases nebulized saline to just help, foster regular airway clearance for them.
Yeah.
I also am really interested in those people that don't progress, and I guess maybe I'm a little one-track minded in that way, but do you discuss the clinical factors that sort of are associated with non-progression? Do you know sort of the immunological background of these patients or microbiota outside of MAC within patients that might sort of mediate most protective
Yeah, so from the immunologic perspective, I don't know that there's a lot of data on that space. And actually, it's sort of interesting because when we think through, patients who develop NTM lung disease, actually, most of them would, by kind of usual standards, be ostensibly normal hosts. The folks that we actually think a little bit more about immunodeficiencies in are folks who have an extensive extrapulmonary burden of disease or disseminated infection, things like that. The predisposition for lung disease almost always has to do with structural lung disease, so things related to COPD, which unfortunately in many cases you can't really reverse, or things like cystic fibrosis, other causes of non-CF associated bronchiectasis. But the lifestyle interventions and environmental mitigation is another piece here. So because we talked about water and soil being such high or big reservoirs for MAC, I often will counsel patients through are you gardening regularly? Are you taking 40-minute showers? Is there any way that we can kind of cut down on potentially the inoculum exposure over time? Those are things that we try to address where possible. To be honest, a lot of the environmental mitigation strategies that have been explored are, in my view, not terribly practical. There's actually one commercially available water filtration system that I know certain patients have tried to install in their households, which reportedly can actually filter down to the micron level necessary to largely eliminate MAC, but they're enormously expensive and they have to be replaced every 90 days. And so that's really something that can probably only be considered by a vanishing minority of individuals, and one that I haven't really advocated for on a broader scale.
Hi, on the hemonc survey, sometimes we'll have very immunocompromised patients who will, on imaging, have malacos. Can you speak to the sensitivity of bronchoscopy or sputum in being able to, for sure detect TN?
Yeah, so I think so. The question was about the relative sensitivity of using expectorated sputum versus bronchoscopy to make a diagnosis of NTM lung disease. And I think that's a wonderful question. I mean, I think a lot of what this has to do with is just the likelihood of sampling error, right? And actually there's some suggestion that sometimes even bronchoscopies can be a little less reliable in some instances because of the dilution that's necessary to, perform the BAL before sending specimens. And it's largely going to depend on, are you in the right space and the right, bronchus where the bulk of disease is. So, I think there's that piece. What I've really found in my clinical practice is if I have a very strong clinical suspicion for NTM lung disease, 3 expectorated sputum cultures are pretty good as a first pass. Most patients who have appreciable disease will be able to cough sufficiently to produce that. And in the instances where they're not able to, I will often engage respiratory therapy to kind of help with induced sputum efforts. And in my experience, that seems to work quite well. I'm not actually aware of any direct comparative literature on the performance between expectorated sputum and bronch specifically for this question, but 3 specimens has been pretty good in my experience.
They might encounter TN is often they get that CT scan that says treating blood nodularities, bronchiectasis disease, and then the question is what's the appropriate diagnostic venue to start that workup? Should I start at sputum in the hospital? Should I send this person to your clinic? What should be the next step?
Yeah, I think in general, an outpatient workup is almost always reasonable and honestly more practical in many ways. The times where I might start to get the ball rolling in the hospital-based setting is perhaps related to the type of patient that was just brought up. So somebody who is immunosuppressed or about to be immunosuppressed for a new reason. And the clinical question is really to try to explore the background burden of disease, some of which might be answered by your CT findings, but perhaps some of which can also be further substantiated by cultures. So if you were seeing somebody with a pretty compelling amount of disease on their CT who again is actively immunosuppressed or about to be newly immunosuppressed, I actually might start getting sputum cultures on those individuals in the hospital. But outside of that setting, I usually just kind of wait till the outpatient setting, because the reality is that the decisions to commence antimicrobial therapy are so complicated. It's such a big commitment once you kind of embark down that journey that I always want to make sure that we have the necessary information and time on the table to really explore those risk benefits with each individual patient.
Let's thank Dr. Lou for wonderful.
All right, thanks everybody.